All right. So coming to the clinical approach to a case of jaundice. So this we all know that jaundice will be seen in the sclera, and icterus will be there. So the level of bilirubin which causes this clinical syndrome of jaundice is more than 2.5 milligrams per deciliter. So remember, the jaundice occur when the levels of bilirubin is serum bilirubin is more than 2.5 milligram per deciliter, and it will be the total bilirubin which is important to cause the jaundice. So what you should ask in the history? So you should ask in the history the color of the urine. That is a very important symptom to be asked, because we may not have the investigations of conjugated bilirubin or unconjugated. We have only total serum bilirubin, or may not be the total bilirubin is available with us. So clinically we are making a diagnosis of jaundice. Ask the patient the urine color. If the urine color is normal, if urine color is normal urine color, we say it as a white colored urine or a clear urine. So that means it is a case of, if it is a normal, it is a case of unconjugated hyperbilirubinemia, because unconjugated bilirubin, remember this fundamental, unconjugated bilirubin, it binds with albumin. So it binds with albumin, and it is not excreted in the urine. So however high is the level, it will not be excreted in the urine. So that will be a case of unconjugated high bilirubinemia. While the other will be if the urine color is dark. If the urine color is dark, that means the bilirubin is going into the urine, and that bilirubin will be a conjugated bilirubin. So if urine is dark, then it is a case of a conjugated hyperbilirubinemia. So this is how, with a simple clinical history, asking a simple clinical history, we can make the initial diagnosis whether it is unconjugated or conjugated high bilirubin levels, which are responsible for the case of jaundice, Now coming to, suppose the patient has unconjugated high bilirubin levels. So there is a conjugated high bilirubin levels. What should we do, and how to approach the patient, or how to approach the MCQ? So look for the keywords given in the clinical history, very important, and how to make a diagnosis from that clinical history. So keyword given as anemia, reticulocyte count is high, and gallbladder stone is present. These are the keywords which are given in the history, in the clinical history or clinical information. So what will be our diagnosis? Remember, the case is a case of a jaundice with normal colored urine, that is a clear urine is present, and we have made a diagnosis of unconjugated hyperbilirubinemia. So anemia, reticulocyte count is high, gallbladder stone is there. Yes, answer, our diagnosis in that case will be hemolysis. So that will be our answer. Hemolysis will be the answer. And remember, in hemolytic anemia, it is the pigmented gallbladder stone which are present. One more MCQ. So these gallbladder stones will be pigmented gallbladder stones. Pigmented. While it is given as patient is totally asymptomatic. Patient is asymptomatic. So let me just decrease the picture size. Okay, so anemia, reticulocyte count, diagnosis is a case of hemolysis. Now the second case. Second case is the case of asymptomatic patient. Lipofuscin pigment is there. Lipofuscin pigment is the key, very important keyword here. Lipofuscin pigment keyword. Deposit in the liver. Our diagnosis, it will be a case of the Gilbert syndrome, lipofuscin pigment asymptomatic patient. While if kernicterus is given in the clinical history, kernicterus is the deposit of the bilirubin in the basal ganglia and in the brain that causes sort of altered sensorium. And if kernicterus is given, then go for the Crigler-Nazar syndrome. Most likely Crigler-Nazar syndrome 1 will leads to kernicterus, and it is a case of unconjugated high bilirubin levels. So these are the important diagnosis from the keywords that you will see, and then make your appropriate answer, appropriate diagnosis. So case of unconjugated high bilirubin levels. Now moving on to the next one. If breastfeeding is given, then it will be a case, it could be some breastfeeding induced unconjugated high bilirubin. So sometime the neonate has low level of UGT enzyme, UDP glucouranosyl transferase, that help in the conversion of unconjugated bilirubin to the conjugated bilirubin. So if that UGT is suppressed, if this UGT enzyme is suppressed by fatty acids in the breast milk, the baby will develop unconjugated high bilirubin levels. So breastfeeding history is given, and then we will go for breast milk jaundice. So this is unconjugated hyperbilirubinemia with the clinical history or the keywords, important keywords to make a diagnosis. Now next, patient is giving a history of jaundice. Urine contains bilirubin. That means urine will be dark colored urine, or very you can say high colored urine will be there. So conjugated high bilirubinemia. In kernicterus, how does unconjugated bilirubin crosses the blood-brain barrier? Because it is immature. Then it can cross. Now coming to the conjugated hyperbilirubinemia, liver enzymes will be the next step. So remember, look for the liver enzyme pattern, and 3 types of pattern you will get liver enzymes. First, liver enzymes are normal. So remember, what is the meaning of the liver enzyme? Meaning of the liver enzyme is the inflammatory liver enzymes like SGOT, SGPT, or obstructive enzymes like ALP, gamma GT, 5' nucleotidase. These are representing the obstructive disease. So this is the meaning of the liver enzyme here. So there will be 3 possibilities. Patient has jaundice, patient has dark colored urine, and a patient liver enzyme is normal. First possibility. Second possibility will be SGPT, SGOT will be high. And third possibility is ALP or gamma GT will be high. These are the possibility according to the liver enzyme status. So let's see what will be the answers with each possibility. So conjugated hyperbilirubinemia, go for the liver enzymes, normal, or SGPT, SGOT high, that is inflammatory enzymes, or obstructive enzymes, ALP or gamma GT. So first possibility, conjugated hyperbilirubinemia, liver enzymes are normal. This is the possibility given to us. And the very importantly, normal liver enzyme, you should know the normal values for these enzymes. And the normal values for these enzymes are for SGOT value, normal value, and I am taking it in international units per liter. So it is up to 40 international units per liter. That is a normal value. While the normal value of SGPT, it is also, most of the textbook says up to 40. While for ALP, that is obstructive enzyme, we will take a round figure, and round figure I will take say as 50 to 150, just as a round figure. Then gamma GT, gamma glutamyl transpeptidase or transferase, transaminase, anything you can call this as T, transferase or transpeptidase, gamma glutamyl transpeptidase. So the value is 10 to 60 international units per liter. Now coming to the liver enzymes are normal. Liver enzymes are normal. Then according to the keywords and diagnosis, let's make a diagnosis. So the diagnosis is, keyword is given as, very important, this question have come many times, jaundice increases on fasting. So prolonged fasting increases the jaundice. And grossly when we look at the liver, liver is black colored liver, black liver. These are the two things which are given. So jaundice increases on fasting, prolonged fasting, and black liver is there. Our diagnosis will be a case of a Dewey-Johnson syndrome. So this is a case of a Dewey-Johnson syndrome. Now, liver is normal, no defect, patient is asymptomatic, conjugated high bilirubin, liver enzymes are normal, everything is okay. Then go for a diagnosis of a Rotus syndrome. Then our answer will be a Rotus syndrome. So two causes where liver enzymes are normal, Dewey-Johnson syndrome and a Rotus syndrome. Now moving on to the next possibility. So come to the next possibility. Hopefully this is clear to all of you. Now the next possibility is conjugated hyperbilirubinemia. SGPT, SGOT are high. High means above the normal range. So inflammatory enzymes are high. Then our diagnosis is, this is a case of, in general, our diagnosis will be a case of hepatitis. This is a case of hepatitis. So again, look for the keywords and try to make your diagnosis. So keywords in the clinical question and the diagnosis. Patient has nausea and vomiting. These are the patient giving this history: nausea, vomiting, and aversion to smoking. Patient is not finding taste or smell in the smoking. Aversion to smoking. This is highly characteristic of कि patient was a smoker and now patient has left smoking. There is nausea and vomiting as the predominant symptom. So always think of liver disease, viral hepatitis. So this is a case of a acute viral hepatitis. So nausea, vomiting, aversion to smoking, given in the clinical question, go for acute viral hepatitis. And depending on the serology, you can then make a diagnosis. If serology is given as IgM anti-HAV, hepatitis A, IgM anti-HEV, hepatitis E will be our answer. So this is how we can make a accurate diagnosis of the acute viral hepatitis with serology. Serology is must. Serology is must. As well as sometimes there can be biopsy finding which will be given to you, characteristic biopsy finding, maybe a diagram based question or maybe just a theory of that biopsy will be given to you. So this is the biopsy which is given to you. Look carefully, look carefully. Arrows. So this is a liver section and look at the arrow mark. So if it is a normal cell, so in the normal cell I will mark a normal cell like this. This is a normal cell, and in this normal cell very well you can see that the cytoplasm and the nucleus is at the center, but in this cell you look carefully, cytoplasm is not clear and nucleus is at the periphery. And the cytoplasm is not clear. Cytoplasm is a ground glass appearance. Look carefully, this is a ground glass appearance in the biopsy. And this ground glass appearance is because of accumulation of HBs antigen particles in the cell, HBs antigen. So this is a case of the diagnosis is clear cut. This is a case of viral hepatitis, hepatitis B. Hepatitis B, ground glass appearance, HBs antigen, HBs antigen. So this is HBs hepatitis B. While if the biopsy is like this, in this biopsy, liver biopsy, you can see all the pattern. All the pattern means ki you can see these cells. They does not stain. They are white colored cells. This is fatty liver. This is a fatty liver. These cells, these are fat. And whatever this blue colored thing you are seeing, the strands, fibrotic strands, this is all fibrosis. This is fibrosis process. So fatty liver with fibrosis, we have the evidence of both the findings, and it is given that it is a case of some viral hepatitis. So the diagnosis here is hepatitis C. Remember, hepatitis C is the viral hepatitis which is associated with fatty liver. So viral hepatitis with fatty liver, think of hepatitis C. Though these slides are of chronic, these are of chronic viral hepatitis. Chronic viral hepatitis, because fibrosis you will see in a chronic viral hepatitis, as well as the ground glass appearance is also a feature of a chronic hepatitis B condition. Chronic hepatitis B condition. So these slides are very important for your subsequent exams, medicine and pathology correlationship. Now, next one, conjugated high bilirubin is there, and patient has SGPT and SGOT as elevated. Again, it is a case of inflammatory response or the hepatitis. Now, keywords and diagnosis. Keywords and diagnosis. So let me see who can give me the correct answer first. So conjugated hyperbilirubinemia, SGPT, SGOT are high. Keyword: high triglycerides, high triglyceride level, hemolytic anemia is there. What is our diagnosis? So remember, high triglycerides and hemolytic anemia points towards a syndrome, and that syndrome is Jeeves syndrome. This is a Jeeves syndrome. Hepatitis is there, and the diagnosis, look at the peripheral smear for this hemolytic anemia. These are all RBCs. These are RBCs, these red cells. And you can see on the RBC, very well you can see there are irregular spikes on the RBC surface. On the RBC surface, you can see irregular spikes. And these are known as typically irregular spikes, acanthocytes. 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 So this will be a case of, so acanthocytes is there, ACANTHO, acanthocytes, and high triglycerides, hemolytic anemia is present. So this is a case of alcoholic liver disease, or this is a case of a alcoholic hepatitis. Alcoholic hepatitis, Jeeves syndrome classically is seen in alcoholic hepatitis. Now the next one, again conjugated high bilirubin levels, SGPT and SGOT are high. Keywords and diagnosis, we have to make the keywords. So keyword is obesity. So patient is a obese, type 2 diabetes is present, and there is this diagram given. This diagram is given. So obesity, type 2 diabetes, and there is on the back of the neck, on the back of the neck, you can very well see This is also a very important complication of insulin resistance, and that is known as acanthosis nigricans. Acanthosis nigricans. Obesity, type 2 diabetes. So this is a case of NAFLD. This is a case of NAFLD, that is non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease. Now, conjugated high bilirubin levels, SGOT, SGPT, SGOT are high. Now the keywords, eye and CNS involvement is given. Eye and CNS involvement along with the liver, and CNS involvement is basically the extrapyramidal pathway, that is tremors are present. Tremors are present. There is neuropsychiatric abnormality. Neuropsychiatric abnormality. And when we look for the eye examination, you can very well see that there is lens is affected, central part has got opacity of the eye, and this is a classical case of, this is not KF ring. Remember, this is not KF ring. This is the sunflower cataract, which is also seen in cases of sunflower cataract, which is also seen in cases of the Wilson disease, and this will cause a decreased daytime vision. Daytime vision. So this is sunflower cataract, not the KF ring, the classical KF ring. While the classical KF ring is brown to green colored peripheral ring at the margins of, or at the periphery of the cornea. And remember, because of this KF ring, vision is not affected. Normal vision is there. Vision is normal, so it is not affected. So this is a case of Wilson disease. Very nice, very nice. All of you are giving me the correct answer. It is a case of Wilson disease. Now, coming to biopsy finding of Wilson disease, and here you can see, if orange colored particles, you can see these are the orange colored particles, orange color in the liver specimen. So just make it a point that it is a Wilson disease. This is a rhodanine stain. Rhodanine stain. So this is all copper. This is all copper, and answer is Wilson disease. By chance they have given you the image or a specimen or the biopsy finding of the liver. So orange color, rhodanine stain. So this will be a Wilson disease. While conjugated hyperbilirubinemia and SGPT, SGOT are on a higher side, keywords and diagnosis. So patient has diabetes, patient has arthritis and skin changes. So remember, you have seen the diabetes earlier also in non-alcoholic fatty liver disease. You have seen the skin changes in non-alcoholic fatty liver disease as acanthosis nigricans. But here the third finding of arthritis will give you a clue that this combination, liver, diabetes, arthritis, skin changes, and skin changes is a bronze pigmentation. Bronze pigmentation. Bronze pigmentation. This will be a case of not non-alcoholic fatty liver disease, but it will be a case where the biopsy specimen will be given to you, and if you find blue colored stains, you can see blue colored. So this is the stain, Prussian blue stain, and it will be staining the iron. Blue colored iron. Yes, very nice. This is a case of nothing but a case of hemochromatosis. Very nice. Now, conjugated hyperbilirubinemia, SGPT, SGOT are high. Now, the keyword, look for the keyword in a lengthy, long stem question. So, if it is written as young female is written, recurrent jaundice is being mentioned. So, young female, recurrent jaundice. Recurrent jaundice means कि jaundice is coming, hepatitis is happening every year, sort of thing is given. So recurrent jaundice, young female, always go for a diagnosis of autoimmune hepatitis. Autoimmune hepatitis. So this will make a diagnosis of the common diseases. Now, conjugated high bilirubin. In this case, come to ALP and gamma GT are high. This is the levels which will be given to you. So it will be a case of, our diagnosis here will be obstructive jaundice. Obstructive jaundice. And what else will give you a clue for obstructive jaundice? In the obstructive jaundice, remember, from the liver, bile flow is not happening into the intestine. This is intestine. Bile or bilirubin is not going, and if bilirubin is not going into the intestine, you will not get, so whatever is formed from the bilirubin, so this will be not the bile and nor the bilirubin, they are not going into the intestine. So as a result, urobilinogen will not be formed in the intestine. It is formed in the intestine and it will provide a light yellow color to the urine. So urobilinogen is a normal component in the urine. So if urobilinogen is not made, so very important point in urine, this urobilinogen is absent. This will be absent. So this will give you a very, very important clue for the obstructive jaundice. As well as stercobilinogen is also not made. Stercobilinogen is not made. As a result, the stool will be pale colored. So pale stools will be there. Clay colored stool will be there, or clay colored stool. So these two important findings will go in favor of the obstructive jaundice. Will go in favor of obstructive jaundice. As well as pruritus word will be given. So pruritus word also go in favor of the obstructive jaundice, because bile then will go to the skin areas and it will cause the itching or pruritus. So this is how to make clinically a case of obstructive jaundice. Obstructive jaundice. Ultrasound will be the next step whenever you are suspecting. Many times this question have come, what will you do next for obstructive jaundice? So ultrasound, common bile duct will be seen, and if bile duct is dilated, so that means it is a surgical cause. Surgical cause. Some extra hepatic obstruction is there, and then you have to go for a CT or MRCP if there is a dilatation. While if there is no dilatation of the common bile duct, it is not dilated, in that case we will go for a anti-mitochondrial antibody. We'll go for a anti-mitochondrial antibody. Non-dilated means either it is intrahepatic obstruction, so common bile duct will not be affected, or it is a sclerosis of all the bile ducts. So due to sclerosis, it is not dilated. So if it is positive, AMA is positive, that means it is a case of primary biliary cholangitis. Primary biliary cholangitis, and it is intrahepatic bile ducts which are affected. Bile duct obstruction, intrahepatic, primary biliary cirrhosis or primary biliary cholangitis. So AMA will be positive in that case. While if AMA is negative, a simple this thing, so that means ki there is both intrahepatic and extrahepatic bile duct sclerosis. Sclerosis of the bile duct, that is known as primary sclerosing cholangitis. Primary sclerosing cholangitis. So this is how we differentiate the conditions of the obstructive jaundice. The obstructive jaundice is mainly seen in cases of the surgical causes. Surgical causes. this will come, yes, this will come. Conjugated high bilirubin will come in a case of a dark urine. Dark urine will be because of bilirubin in the urine, conjugated bilirubin in the urine. So yes, there will be a dark urine in obstructive jaundice, dark urine in the obstructive jaundice as well. So dark urine is because of the high bilirubin, conjugated high bilirubin. Now let's solve some MCQs and see how to solve the long stem MCQs which are given to you. So this is a long stem MCQ which is given. So how to look for the keywords. So 26-year-old male presented with yellow eyes. Now look at the keywords. Yellow eyes I have marked. Patient has icterus. Patient has icterus. But there is no history. Remember, negative history is also equally important. There is no history of nausea, abdominal pain, no dark urine, no light colored stools, no pruritus. So that means there is no conjugated high bilirubin is not there. So in that case, there is no conjugated high bilirubin which is causing the problem, because dark urine is absent, light colored stools, pruritus, that means obstructive jaundice, is also not there. Then on examination, scleral icterus is present, so that we identify as the keyword. And in the investigation, so what are the other findings? Other findings are normal. Abdomen is soft, non-tender, liver span is 8 cm to percussion, edge is smooth, liver is palpable only with deep inspiration. These are all normal findings. So we are not interested in those normal findings. The main is the bilirubin level on the investigation. So the total bilirubin is 3 with a direct bilirubin of 0.2. So that means the indirect bilirubin here will be, or unconjugated bilirubin here is mainly elevated 2.8 milligram per deciliter. So this is unconjugated bilirubin. This is our diagnosis. That is elevated. AST, ALT, alkaline phosphatase are normal. So that means liver enzymes are okay. So what is the most likely diagnosis? So the answer here will be autoimmune hemolytic anemia, Crigler-Najjar syndrome type 1, Duane-Johnson syndrome, or Gilbert syndrome. So in that case, autoimmune hemolytic anemia is unlikely, because hemoglobin, LDH levels and heptoglobin levels are normal. It is clearly mentioned. So these findings, if they were abnormal, then you can think of autoimmune hemolytic anemia. Then Crigler-Najjar syndrome type 1. Remember, Crigler-Najjar syndrome type 1, the lifespan is less than 1 year. Without treatment, patient will not survive. So lifespan is less than 1 year. Without that, patient will not survive, and 26 is the age given. Duane-Johnson syndrome is unlikely, because it is a case of conjugated bilirubin elevation. While Gilbert syndrome, yes, it is most likely a patient of Gilbert's syndrome. Patient has yellow eyes, especially when patient is stressed out, or patient has taken some alcoholic drinks, or patient is having fasting state for a long time. Then yes, it is a case of a Gilbert syndrome. So by exclusion, we can make a diagnosis of Gilbert syndrome. First is we have to identify whether it is a indirect or direct. And then what is the exact cause of that indirect hyperbilirubinemia. Normal values we have already discussed in the previous slide. Now come to the next question, MCQ. 15-year-old male patient develops mild jaundice while being treated for a urinary tract infection with cotrimoxazole. So patient has mild jaundice. So jaundice history is there. Look at the history. Keywords: jaundice. Urine bilirubin is negative. If urine bilirubin is negative, that means it is a case of unconjugated high bilirubin. It is a case of unconjugated high bilirubin. So serum bilirubin is 3, mostly unconjugated. So that is given in the question. Now the most important part is how to make the etiology. So look at the hemoglobin is 7. So hemoglobin is 7, low hemoglobin. We have made the keyword anemia, that will go in favor of hemolysis. So only this point is sufficient to make a diagnosis of the hemolysis here. The most likely cause of this jaundice is, yes, it is a case of hemolysis. But why hemolysis in this case? Just look at the clue. Patient was treated with cotrimoxazole, sulfonamide. So it could be a G6PD deficiency. This could be the trigger, cotrimoxazole, that has caused the hemolysis here. While Gilbert syndrome is mainly asymptomatic, hemoglobin is normal. There is no problem of hemoglobin in Gilbert syndrome. Crigler-Najjar syndrome type 2. So Crigler-Najjar syndrome type 2, here it could be a possibility, but hemoglobin levels are normal in Crigler-Najjar. There is no abnormality of low hemoglobin here. Drug-induced hepatitis. One might think that patient has taken the drugs, so it could be a drug-induced hepatitis. But remember, in a drug-induced hepatitis, conjugated bilirubin will be high, because it is causing the liver damage, and whatever conjugated bilirubin has made, that will leak into the plasma, So this is a case of a hemolysis. So this is how to approach the MCQs, and this is our approach at DAMS. Ki we make clear ki how that answer is correct. We rule out other options. And how to rule out the other option? The clinical approach of a case, any case of a common symptom, and art of solving the MCQ, how to rule out these options. So with this, we finish with the today's session, and today's session was on the clinical approach to the case of a jaundice, So with this, we will finish with our session for today. And just as a reminder, DAMS has launched the ultimate live course, which is just like your regular batch. All the 19 subjects, 750 hours of live hours of teaching, recorded videos will be given to you, DVD will be given to you. First 1000 students will get the concept book, hard copies, all the grand test, DAMS question bank. So this will be included in the DAMS Ultimate Live course. So best wishes to all of you, and have a happy and enjoyable reading for your exams. Thank you, all of you.